All right, let's go ahead and get started. Good morning, good afternoon, everyone, and good morning to those that are joining us from the West Coast. Welcome to today's webinar. On behalf of Muscular Dystrophy Canada, we're really pleased to have this webinar as part of Spinal Muscular Atrophy Awareness Month. And this was actually based on a lot of questions that we would receive in the research hotline around speech and swallowing. So we have this webinar today on bulbar function. We have here Dr. Colleen O'Connell and Susan Howey, who are here from Stan Cassidy Center for Rehabilitation. I'll pass it over to both of you and thank you in advance for preparing this presentation. We've had a lot of engaged participants here today and ready to listen. Over to you.
Thanks so much, Amir, and welcome everybody. It's our pleasure to be joining you here from East Coast Canada. And myself and Susan are happy to be with you today to talk about an extremely important area of function that unfortunately gets a lot of underappreciation, particularly from healthcare professionals. But hopefully now after this, you'll all feel a bit better equipped to be your own advocates. And we can also continue to work harder on improving our assessment and management of bulbar symptoms. So our goals for today is that you have a bit of a better understanding of what is meant by bulbar function, that you'll be able to recognize what a person feels or what they may demonstrate, what we call the signs and symptoms of bulbar weakness. We'd like you to appreciate how bulbar function can affect you in an everyday life and understand how health professionals, how we assess, evaluate, and monitor bulbar function, and then learn a little bit about the various ways that bulbar issues can actually be managed in working with your health professionals. So one of the first things is, why do we even have this word bulbar? It seems quite silly, and how does it relate to anything in our brain? So the word bulbar is actually just describing the shape of the area of the brain that is involved in the processes that those nerves eventually go to supply. So the bulbar area is actually in the brainstem area of the brain. If you look at this sort of little pink area here, if you can kind of picture the little bulges up at the top of the brainstem here, you can kind of think they look a bit like a bulb. That's where the word bulbar comes from. And that area of the brain gives rise to the cell bodies and the nuclei of a number of nerves that go to supply all of those muscles that we use in our speaking, in chewing, and in swallowing. So these are generally the muscles around parts of our face and our neck. And those are areas that if those muscles become weak, you can then experience a number of different symptoms that we call our bulbar symptoms. So these include things like difficulties with swallowing, changes in our speech or how you're able to articulate your words. Also, people have problems with secretions. I'll have patients that complain of that, gosh, I'm drooling or my mouth is getting filled with saliva. That's part of some of the bulbar weakness. We can also see difficulties with chewing because the muscles, including your tongue, which is a really big muscle, are affected, and therefore it makes it more difficult to prepare the food and getting ready to swallow. So those are all great because those are things that we know that these muscles do, but what about persons who are living with spinal muscular atrophy? What do they say are the problems that they experience? This is a nice study that was just published a few years ago, where it used a tool called a patient-reported outcome and asked specific questions about persons' experience who are living with SMA and the problems that they had around things such as speech and chewing and swallowing. And so these are the most common complaints that persons living with SMA had. They described jaw problems, and that includes even with mobility of the jaw. They said they would get tired when they're chewing their food, feeling like they're choking when they're eating, difficulties with their speech intelligibility, that people can't quite understand them. And often these things would all be found together. all of these things, if you think about what we do when we talk, we're communicating. How social are we when we're eating? Often many social events are around food and drinking. If you're having problems in these areas, this is going to impact on your quality of life. This will impact on your overall well-being. It's a negative factor for social participation if persons are having problems with their speech or their swallowing functions. What we also know as well in persons with spinal muscular atrophy, that these problems tend to be greater with the more severe forms of spinal muscular atrophy. So we see a greater degree of involvement in persons who have greater physical involvement with other areas of function, such as head and neck control, trunk stability. Now, I know a number of you, particularly in this new and exciting era that we're in terms of drug treatments being available. Well, and how do these drug treatments possibly help with speech and swallowing symptoms? Unfortunately, there has not been a lot of involvement specifically of speech and swallowing measures in the disease studies that were done. So a lot of what we're learning is coming back retrospectively or looking forward now with people who are on drug treatments and looking at their experience, what we call real world evidence. This is a study that was recently published that looked at a small group, only 24 people. These were all adults who are being treated with nusinersen, and looked at what their expectations of disease treatment were, and as well used what's called a patient-reported outcome measure. So they didn't do a formal test to check speech or swallowing, but they asked the individuals their feedback on how they felt their function was. And they found that among those patients who were on treatment, and this was just within the first 10 months of observation, that 13% reported some improvement in their ventilatory and their bulbar function. And this was mostly in the SMA type 2 group. And what's really important is that no one reported, again, keep in mind this was only 24 people, but no one reported a deterioration in their bulbar function over that 10 months. And often in persons who are older with SMA, maintaining function and not losing function is a very reasonable goal for drug treatment. Now, there's been a few recent studies reported in infants, and infants being treated can be of two different types. There's infants who are treated pre-symptomatically, so that's usually when they're captured by newborn screening and being treated with the one-time dose treatment of the gene-modifying medication. Or there are infants who are treated once they are symptom onset. And again, please keep in mind, these are very small numbers, and this is data that has really just been emerging as we've started to recognize people are living with SMA. And now we realize, wow, we really should be paying a better attention to speech and swallowing types of functions. I've given you here on the slide two recent studies, one that looked at a very small group of just 24 patients. This was in the United States, and they used one swallowing measure as a score. And this was a group treated with nusinersen, and just over the first, I think it was 18 to 24 months, and they did not find an improvement in speech and swallowing, and that there was still a need for tube feeding in some of the more severely affected cohorts. However, in a group that had asymptomatic or pre-symptomatic treatment with onesizefitsall, and I apologize if I pronounced that wrong, but this actually had some very good outcomes. Again, this was pooled with a phase 1 and some phase 2 studies, so only 65 patients total. But this group did show very nice endpoints in terms of numbers that had normal swallowing and had full nutrition at the end of the 18 to 24 months. So what we're looking at now and this is really exciting. So 10 years ago, 100% of infants with SMA type 1 needed a feeding tube by 12 months of age. But now, and this is just published within the last month, this is in one of the studies of pre-symptomatic at the study end at 18 and 24 months, 100% of the patients who received treatment were swallowing normally and were able to have full oral nutrition. So this is extremely exciting. So this reinforces just how important it is for us to look at having good measurement tools so that we can monitor and evaluate patients. So this was a study that was recently published as well, just a few months ago, that tested a couple of different measurement tools for evaluating both voice and for evaluating swallowing. And this used measures that we call patient-reported outcome measures, which are really important because it's taking the experience and the perspective of the person who's actually living with the condition. So this was 47 persons who completed these questionnaires. 94% of them reported some voice problems. 85% of them reported swallowing problems. So this was a population, all of the individuals were wheelchair users. What they did find was that the swallowing did correlate a little bit with the upper limb measure study that we are typically doing. But what's nice about these measures is they're really easy to do. They don't require any special equipment, but they give us some really nice details as well about the specifics of what an individual is experiencing. So for example, the voice handicap index can give us information such as, people have difficulty understanding me in a noisy room, or I run out of air when I talk, or I feel left out of conversations because of my voice. The eating assessment tool can also help us pinpoint where people are having problems and therefore where we can intervene. So for example, when I swallow, food sticks in my throat, or swallowing solids takes extra effort. And so it's important for us to use some of these measures and to be able to evaluate our patients on an ongoing basis, not just so that we can say what a treatment is doing or not doing, but we can look at the individual and treat them as an individual with recommendations to help their function. We are trying to identify what are the very best, simple, accessible measures that we can do that are meaningful for people. Some of them that we're testing right now and trying out are things like the maximum phonation time, how long you can withhold a single syllable. We look at what's called the Egan classification scale. This is a more general measure. It's used in individuals who use a wheelchair as their main means of mobility, but it can pick up on a lot of nice oral function and voice function scales as well. There's been some recent publications on using maximum tongue pressure, but that does take a little bit of a special device, or maximum mouth opening, which is actually very easy to do. And what's really fascinating is the maximum mouth opening could predict what type of SMA an individual had, even down to how many copies that they had of the SMN gene. So those are great. They help us with research. They help us with monitoring progression. But what is the most important is that we take an individualized approach to the assessment and management. And that is where we really rely on our speech language pathologists, and where I'm going to hand over now to my colleague, Susan, to continue from here.
So hello, everyone. I'm also thrilled to be here to discuss bulbar function in spinal muscular atrophy with you all. And so I'm just going to pick up where Dr. O'Connell left off. And first, just to kind of summarize, so I'm going to be discussing assessment and management of speech and swallowing for people living with SMA. And I wanted to give you a little bit of a heads up that I will be highlighting one specific treatment of speech and communication known as augmentative and alternative communication, because that is my current area of clinical specialty and interest. Also, all of my experience as a speech language pathologist has been working with adults. So this portion of the talk is really going to focus on that. So it's not going to be a surprise to any of you to hear me say that there isn't a one-size-fits-all approach to speech and swallowing management for people with SMA, as Dr. O'Connell alluded to. So we really do see the full range of bulbar function from no signs of weakness, of bulbar weakness, up to significant fatigue and weakness. So since it's not possible to know really at the outset how speech and swallowing will be impacted and progress, we really need to tailor our recommendations to each person individually in the context that they're in and for the activities that are important to them. It's also important to note that we really can't discuss speech and swallowing without considering respiration. And that's because there's a number of ways that they're linked. So respiration does drive speech, as you can well imagine. The first thing you do before you talk is you take in a breath, and then that breath supports your voice and speech function going forward. Also, respiratory muscles are used to clear the airway, which is so important for swallowing safety. So if some material does go the wrong way into the airway when you're swallowing, then you need to use your respiratory muscles and voice muscles to try to clear the airway. And also just a note that breathing and swallowing are coordinated. So we have to time the end of our breath with the swallow and then restart the breathing after the swallow. So the breathing and swallowing and speech are so intimately connected. Okay, so now let us considering swallowing to start off. So just keep in mind that this includes chewing and swallowing not only of food, but also medications, liquids, whatever your favorite beverages are, and also secretions, so swallowing saliva, which we all do regularly through the day. So now, what are signs of swallowing problems? I'm just going to elaborate a little bit and reinforce what Dr. O'Connell had mentioned. So one of the first challenges that can be noticed is sort of slowness and extra effort for chewing and swallowing food, which leads to a longer time required to finish a snack or meal. So that can be one of the early signs. Also, as previously mentioned, difficulty chewing is often reported. Could be leaking of liquid or food from the mouth. Food or liquid can also get stuck in the mouth, either pocketed in the cheeks or stuck on the tongue after the swallow. And then looking at during or after the swallow, coughing can happen if there's difficulty swallowing. So that would be an indication that some material had perhaps gone the wrong way into the voice box and the upper airway or gotten stuck in the throat. As throat clearing and gurgly voice quality are also signs that perhaps some material had gone the wrong way towards or into the windpipe. Sensation of sticking of food in the throat, and also difficulty breathing after eating or drinking can all be signs of problems. So again, to reinforce what Dr. O'Connell had mentioned, so this has a huge impact on day-to-day life. So the first way that can impact our lives, obviously, is that if it takes extra effort and time to finish a meal and our snacks, it can be hard to take in enough nutrition to maintain healthy nutrition and hydration. So malnutrition and hydration can be a consequence of swallowing difficulty. Also, aspiration pneumonia is another important thing to consider. So if food, liquid, or secretions go into the windpipe during or after the swallow and eventually into the lungs, this is called aspiration. And it can lead to one form of pneumonia, which is aspiration pneumonia, particularly if there's a higher amount of respiratory viruses and bacteria in the mouth and throat that get carried along with that material towards the lungs. And so, if you have all those extra pathogens, and if the immune system isn't strong, that can more easily lead to pneumonia. Another consequence, of course, is reduced quality of life. So we get so much enjoyment and social time around meals. We share meals together, we might go for coffee. And so when it's hard to eat, that can impact our relationships and how we participate in family traditions, et cetera. And that yeah, it impacts our social well-being as well. This picture just kind of illustrates that, and regardless of what holiday you celebrate or how you share time as family and friends, you can see in this picture how much both, eating, there's a lot of different kinds of food there, can be difficult to swallow, and then all that social time as well. So if there is weakness in the bulbar muscles, it can really affect the quality of our social interactions. Okay, so now moving on to how do we measure swallowing function, and I'm just going to elaborate on this a little bit. So as referred to, patient report measures are very important. And so one of the easiest tools that also gives us a lot of great information is this eating assessment tool, the EAT-10. We can monitor in different ways. We can keep track of dietary intake as reflecting swallowing function. There are also a number of swallowing screening tools out there. One is the 3-ounce water swallow test. And this is where you would continuously swallow 90 milliliters of water, which is actually kind of tricky to just chug that. And then you look to see if the person's able to finish it and if there are any difficulties with that. There are instrumental assessments. One, a gold standard is the video fluoroscopic swallowing study. And that's an X-ray video of someone as they're eating and drinking, and the food and liquid is mixed with contrast so that you can see it on the X-ray. And then another type of instrumental assessment is endoscopy, which is where a small tube with a camera and light is put into the throat so that you can see what's happening during the swallowing. The penetration aspiration scale is commonly used in conjunction with instrumental assessment, and it's a rating scale that evaluates airway protection during and following the swallow. And then respiratory measures are very important here. So one that looks at airway defense capacity is peak cough flow, and that's really important to consider when we're evaluating swallowing function and those airway protective measures. Okay, so what can be done about dysphagia? And I'll just give you a heads up. Dysphagia is just another word for swallowing difficulty. So one approach to this is what we call compensatory, where you put a strategy in place to improve the swallowing. So some examples there are optimal positioning to make sure that gravity is helping you in the right way, and also positioning of the head. So is it going to be tucked or turned or tilted? Some different head positions can be helpful for swallowing. Environmental modification, so just literally how is the area that you eat in, how is that set up, how distracting is the environment? Are you likely to talk a lot during the meal if lots of people are around? I use the term equipment a bit loosely there, but there are different types of cups, for example, that can deliver a certain volume of liquid, or that are cut out in a certain way to make your head posture more optimal. But there are also different types of feeding equipment out there that can be helpful. Pacing and feeding strategies. So how big is your bite? How big is your sip? Are you going to pause between bites and sips? And there are a variety of swallowing techniques, some of which incorporate like a breath hold or a cough or a double swallow into your swallowing to help make it more safe and efficient. And then one of the better known ones is diet texture modification, though that's just one of many strategies to help manage swallowing difficulties. So looking at which types of foods are safest and easiest to chew, the softer, moister food may be easier. And in terms of liquids, if the unthickened kind of regular runny liquids are difficult, then we can look at using some thickeners to give you a little more time to swallow safely. So that's another common intervention. Okay, moving next to rehabilitative approaches for dysphagia management. So in this case, instead of putting a strategy or some kind of equipment in place to temporarily help function, as long as the strategy is in place, the aim of a rehabilitative approach is to promote maintenance of function or even gradual gains by changing the underlying physiological function. So this approach is more exercise-based, looking at resistance exercises. But there's a couple of important points about this. In spinal muscular atrophy, it is important that the exercise is consistent and moderate. You don't want to be doing any sort of sudden increases of intense exercise, because that can cause unnecessary fatigue and make things more difficult. So really the concept there is to avoid overexertion if you're using some of these exercises in a rehabilitative approach. So the first rehabilitative approach that is gaining some evidence out there in the literature is respiratory exercises, in fact. So one of them there is EMST, which is expiratory muscle strength training. And you blow through the device hard enough to release a pressure loaded valve. And this has been shown to improve cough function, of course, for airway protection. But there's some emerging evidence that it may actually improve swallowing because it uses some of those same muscles in your neck that you use during swallowing. So it's the kind of thing that may be helpful, but it's not going to hurt if it's practiced in a safe way under the direction of your clinical team. But even other respiratory interventions like lung volume recruitment, which is that blue bag there, or even some intervention for cough, those also can be helpful for airway protection and help with swallowing safety. So another rehabilitative approach that is gaining some evidence out there in the literature is tongue strengthening. So this device is called the Iowa Oral Pressure Instrument. And you can see the little blue bulb there on the end of the tube. You put that in your mouth on top of your tongue, and then you press your tongue, for example, up into your hard palate. And then there's a number that's generated on the screen there that tells you how hard you're pushing and how strongly you're pushing. So that's a form of biofeedback to help you strengthen your tongue. So the last approach for management of swallowing difficulties that I'm going to review is surgical approaches. And really the most relevant here for SMA is feeding tube placement. And so in a case where the swallowing difficulty is quite significant and it's very difficult to meet nutrition and hydration needs, this is something that can be considered. And I'd like to point out that this can be for supplemental nutrition or for full nutrition and hydration. So there are many cases where a feeding tube is placed, and that doesn't mean the person necessarily stops eating or drinking altogether, but they may eat some by mouth. And then if it's tiring to meet all of their needs that way, then they can have some supplemental feeding. And that takes the pressure off to maintain their nutrition and hydration by eating and drinking by mouth. Okay, I'm going to give a plug now for oral care, and you can see it's written in red. That means I'm serious. It's the only slide that I've titled in red. And it takes on extra importance in the context of swallowing difficulty. And in fact, it's something that is often neglected, particularly if nutrition is not received by mouth. If someone has a feeding tube, we tend to kind of forget the importance of that. And why that is important. First of all, it's because, as I was alluding to before, there are respiratory pathogens that potentially in our mouth and throat. And when you brush your teeth regularly, there's going to be less of that colonizing your mouth and throat. So then if something goes the wrong way when you're eating and drinking, then at least it's not going to be carrying with it all of that extra bacteria and virus and things that might cause a person to be at higher risk of getting pneumonia. So certainly continue to take regular care of your mouth, toothpaste and toothbrush, and to do that regularly, morning and evening, but also before or after meals as per direction from your clinical team. Okay, the last aspect of swallowing treatment that I'm going to mention is saliva management. So examples of difficulties in this area, just to review, could be drooling or leaking of saliva from the mouth, or even sometimes coughing when swallowing saliva. And there are different approaches you can take to manage this. Sometimes just from making an effort to swallow more often to clear that saliva from the mouth, or even if there is a bit of leaking, having a cloth or something on hand just to manage that. But also another suggestion is a suction machine. And so this can be used just to literally suck out the saliva if there's a buildup in the mouth. And that's another common intervention recommended. And there are also quite a number of medical interventions there that can be helpful. So medications and other medical interventions. And I just wanted to mention all of this just to be aware that there are a number of options for saliva management. And so it's worth bringing it up with your healthcare team if that's a concern. Okay, so next, moving on to speech. So first of all, what are signs of weakness in the speech muscle? So just kind of to review there, can be imprecision in speech sound. So speech sounding slurred or more difficult, less clear. Nasal sounding speech. So if there's weakness in the soft palate, sort of at the back of the mouth, more of the sound can be coming through the nose. And so it can lead to a nasal sounding voice. Again, looking at, well, due to a combination of voice and respiratory muscle weakness, there might not be enough air to keep going for a long statement, so phrases can become short. Speech can be quiet if there's voice and respiratory weakness. The voice might be breathy. That's a sign of voice weakness. You can also run out of breath when you're talking, so you might be saying a sentence and it kind of peters out at the end if there isn't enough respiratory support there. And also just in general, increased effort to talk. So it takes a lot of effort to project the voice and be well understood if there is bulbar muscle weakness. And so what does this mean for daily life? And just a note there, dysarthria is sort of the clinical term for speech difficulty. So when speaking is difficult, people report that it can be tiring and frustrating to talk. And so this is going to impact conversation. You may want to jump into the conversation less often and take more of a back seat during conversations. And there may even be outings or activities that a person might avoid because of the extra effort required to talk. Also, people report to us that they don't go to as many places maybe as they used to as speaking is difficult. And also just considering like a face-to-face conversation versus distance communication, so talking over the phone or possibly even a video call. So people report that it's harder for them to read the listener's signals when it's not face-to-face. So they are less certain whether the person understood them or not. So that makes it harder. But also, especially on the phone, when you don't have that visual, the listener can't, sort of read your facial expression and your mouth. So it's harder for them to understand when they don't have that visual picture. So sometimes people report that they speak on the phone less or maybe not at all. And another important thing to mention that people do report is because of this change in communication, it can even impact their self-concept and certainly their relationships. So when there's any change in communication, that's going to affect all of the important and even less frequent relationships in our lives. Okay, now turning to measurement of speech function. As Dr. O'Connell mentioned, maximum phonation time is a common one. It's quick to do. You just record the number of seconds that a person can sustain a vowel, and it's ah, so you can kind of see how long that can be sustained, and you can track that length over time. Patient report measures, again, the Voice Handicap Index is a great one, and it really looks at voice as well as speech function in a variety of meaningful contexts. Measures of speech intelligibility. So oftentimes it's what percentage of words that a person says or reads aloud are understandable to a listener. Measures of speech rate, for instance, how many words or syllable per minute a person is saying. And so we can track that over time. Is speech becoming slower, for example, or staying the same? And then perceptual evaluation. So that's really listening to the speech and determining what aspects of speech are successful or challenging, and sort of what the quality of the speech is like. Okay, so now management of speech problems. So going first to the compensatory approach, or what strategies can be used to help speech be well understood. So certainly optimizing lighting and positioning. So you want to make sure that the listener can see you well. So, a dark room, it's harder, or if you're seated far away, or if you're not seated face to face, it's more difficult. Reducing background noise is probably the easiest thing that we can do. So turning off the radio in the background, or closing the door if it's noisy in the hall. Getting the communication partner's attention before talking. So making sure they're focused on you before you speak, that can be helpful. Pacing aids are just a little something you can kind of touch or be aware of to help you slow down your speech. And you want to make sure you have good posture. So whatever posture for you helps you maximize your respiratory support is the posture you want to be in for a good conversation. And finally, energy conservation strategies are important. So obviously if you're tired, it's harder to talk. So you want to make sure that you're spacing out any tiring activities so that they're not all at one time of the day, and taking breaks and that sort of thing. So one type of equipment or device that can be helpful for speech after a tracheostomy is a speaking valve. So this is a one-way valve that is put on the end of the tracheostomy tube, and it allows you to breathe normally in, you see with the red arrow there, but then when you breathe out, there's a valve that closes. And then with the green arrow there, you can see that the air is instead directed through the voice box and the mouth, and that makes it a bit easier to speak clearly. So yeah, that's a possibility for a person with a tracheostomy, and the ear, nose, and throat doctor, respiratory therapy, and speech language pathology will often assess to see if that's a possibility. Now, in terms of rehabilitative approaches, the exercise-based approaches for speech, it really involves practice of slower speech with larger movements and getting a full breath when speaking. And also respiratory and voice exercises can be helpful, and your speech language pathologist can help you determine which of these exercises are good to try, again, at that sort of moderate intensity without over exertion. Okay, I'm going to go now into augmentative and alternative communication. So this is a strategy too. It's more of a compensatory approach, but it's really any strategy, tool, or device that can be used to augment or supplement speech, or at times even to replace speech when talking is difficult. And I'd like to dispel a misconception about AAC, which is that it's an all or nothing thing, kind of like I was mentioning with the feeding tubes actually, but there are many people out there who use AAC sometimes, but not all of the time. So when might a person consider using AAC? Really in any situation where speaking doesn't get the full message across, or you want to add to the spoken message, and at times when speaking is not possible for a given reason. For example, a backup strategy for speech may be helpful if weakness or tiredness make it hard to speak clearly, either all of the time or at certain times a day. Or let's say a breathing machine like a BiPAP is in place with a face mask that makes it hard to talk, then AAC can be used in those situations. Or even in a really noisy room where it's really hard to talk over the noise, AAC can be helpful. So there's unaided AAC, which is just when you don't use any really outside tool, it's just using your face and your hands and your body language to emphasize or add to what you're saying. Lowtech AAC is really anything that doesn't have a battery or needs to be plugged in and doesn't have an electronic component. And these are simple and easy to use. A common example is alphabet boards, and I'll just run through a few examples. They can be alphabetical or organized like a keyboard on your computer, the QWERTY layout. And you can add, as you'll see in the bottom there, some spaces for extra messages that you can point to or indicate, such as a space, you'll see there, which is an indicator to the listener that you're switching to a new word. And you can also have alphabet boards that have extra messages and words that are commonly used, as you see here with this AlphaCore board. Another low-tech tool is just a communication page, book, or a board. So really just a sheet of paper or otherwise that has important phrases written on it that the user can point to or indicate in another way instead of spelling it all out letter by letter. So it can be one page or multiple pages. And it could even be as simple as attaching a written message to a handy spot like the arm of a wheelchair, as you see here. This is an example of a communication flipbook where you'd have messages written in the boxes and then organized by topic with tabs. Low-tech AAC can be used as well in a case where it's hard to use your hands, and you can use your eyes maybe to point and indicate. This can be as simple as placing written messages in locations close enough for you to see, but far enough away that your communication partner can tell where you're looking. So maybe, the four corners of a TV screen or on different walls. Another example of an eye gaze tool is Speakbook, and I'm going to show you a quick video about how this works.
This is a Speakbook. I will say good to see you by first looking up to that quadrant, and then secondly by looking up towards the pink dot. Good to see you.
And the next one is an Etran board, which is similar to the Speakbook, where you just would look at different areas to spell something out or to say messages. And the next one is iLink, and it's a see-through display that you kind of lock eyes with between the user and the support person. And I'll show you a quick video of that one.
This is an iLink board. You start by looking through the display at the smiley face, and the user does the same. Then the user looks towards a particular letter and locks onto that. And then you move around the communication display until you're looking directly at the user's eyes through a target letter, which in this case is H.
Okay, so now moving on to electronic AAC. And I just want to say that one of the most useful forms of AAC that we found is just a voice amplifier. So if you have a quiet voice, or if you have reduced breath support for speech and it's hard to speak loud enough to be heard, you can consider a voice amplifier. And it's really just a microphone that you wear somewhere close to your mouth that's connected with a speaker, and it gives your speech and voice a boost in loudness. This helps to increase endurance because you're not sort of fighting to be loud enough to be heard, and it can reduce fatigue. So the microphones can either be wired or wireless, so they can be connected to the speaker with a wire or without. Without the wire, it makes it a little more flexible. And the microphone can be worn on the head or even on a lapel. And there are even transdermal microphones that are helpful. Like, let's say you're wearing like a BiPAP mask, and that amplifier isn't going to be much help close to your mouth. So you can wear a mic that has contact with your skin and can help to make your speech louder. Okay, so in our clinics, the most useful type of electronic AAC tends to be a communication app that's loaded onto a smartphone or a tablet. So these devices are familiar to many people, and they may already have them, in fact. And so it makes it an accessible and easy way to use electronic AAC. And so that's what I'm going to focus on in just a few more slides. Just to review quickly, text-to-speech apps, which means an app that you would type into or select a message, and that will be spoken aloud. That's what I mean by text-to-speech apps. So on Apple devices, a great one is Speech Assistant AAC. It's $28, so relatively not too expensive compared to some others, but it's very user-friendly. And next, I'll show you on the next screen how this works.
Hello, how are you? What is your name? I'm Susan.
And so Predictable is another example. It's more expensive, but has a few more bells and whistles. And if communication apps is something you're looking into, again, don't hesitate to ask to be connected with a speech language pathologist that can help you figure out which one is right for you or best for you. And if you're looking just to try a text-to-speech app to try the concept, there is a free one on Apple called Text-to-Speech, and the exclamation mark is important with that one when you're searching it up. It's more basic, but still gets the concept across. And Prolocal for text is another fairly well-known one. It's a little less user-friendly, but is great for bilingual users. So text-to-speech apps on Android, again, Speech Assistant has an Android version that is free, but it has a few less features than the Apple version that is paid. And Predictable also has an Android version. So Action Blocks is one of my favorite apps. So it's been created by Google, and makes customizable buttons on the home screen of the Android device. And you can hit those buttons to carry out specific actions like, sending a text, launching a call, but you can also make it speak a message. And so I'll show you what this looks like. And basically you can turn the home screen of your Android device into a speech output communication board like this.
Excuse me, I have something to say. That's great. What time is my appointment?
So you can see there by touching the buttons at the top of the screen, a message is spoken. So Project Activate is another Google project for Android devices. That's great. Basically, you can make your device do actions, including say a message by say smiling or looking up. And this is how it works.
This is Project Activate. I'm going to make the phone say thank you by smiling.
You.
So it's kind of cut off there, but it did say thank you in response to the smile. There are also text-to-speech apps available for Windows computers, and it basically turns your online keyboard into something that will speak phrases and messages aloud. So there are several free ones that work fairly well. So AlphaCore, Talk for Me, and eTriloquist are some free options there. And there is more sophisticated communication software available that will work as a text-to-speech function on the online keyboard, but it also does a lot of other things, from social media to calculator. It's quite powerful software. So some examples there are MindExpress, Grid3, and Communicator 5. Okay, so one really interesting thing to know about communication apps and software is that it's getting easier and easier to customize the voices used for speech output so that the voice used in the device sounds more like you. So this voice customization just involves making recordings of your speech. You take time to make these recordings when your speech is strongest. And that way, if there's ever a time when you'd like to use a communication app to speak, such as when your voice is tired, or you're in a noisy area, or if there's any future reduction in speech clarity, then your communication app is ready to go and will sound more like you. So there's two ways to do this: voice banking and message banking. So message banking is very simply just recording a series of personally meaningful phrases or messages that can be uploaded into a communication app or device and later played back exactly as they were recorded. And voice banking, on the other hand, is recording a sample of speech that's processed by AI or computer software to make a custom digital voice that sounds close to your voice. I'm going to show you an example. First of all, I'll just tell you some common services for this. So the Voice Keeper, Acapella My Own Voice, and Speak Unique are options, and they all have different disadvantages and advantages. I made a Voice Keeper voice for myself, so I'm going to play this for you so you get a sense of what it's like. First, I'm going to read the sentence live, and then I will play it so you hear what my synthetic voice sounds like. So the message is, "Hi, my name is Susan. I'm glad to be joining you today from Fredericton, New Brunswick. Have a great day."
Hi, my name is Susan. I'm glad to be joining you today from Fredericton, New Brunswick. Have a great day.
So you can see it doesn't sound exactly like me. It doesn't have the same tune and quality of speech, but you can tell that it's me, and it certainly sounds more like me than my Siri voice does on my phone.
Hi,
One further note about voice banking: Apple's next update, Apple 17, which should be coming out soon, is going to include something called Personal Voice, which is basically a free voice banking service. So for Apple users, this is going to be an option, and I'm excited to see how well it works with the communication apps mentioned. So I know we're running out of time, but before I wrap up, I just wanted to highlight some systems or strategies that can be used when you need help. So for example, if it's hard to go and get someone when you need assistance, and it's also hard to shout loud enough for them to hear, it would be important to have an alerting system. So some examples would be just, knocking or making noise in some way, or a bell or a buzzer. Baby monitors are something that is commonly used to help communication if someone's in another room. wireless doorbells or personal pagers, just a smartphone, so you might send someone a text, walkie-talkies, and then the last suggestion is the intercom feature on smart speakers. So if you're close enough to the smart speaker that it can hear, you can say, you know, hey Google, broadcast something like I need to be turned. So hey Google, broadcast I need to be turned. And then if someone is in another room and they also have a smart speaker there, they will hear the message. And also, particularly if speaking is difficult, it's important to have communication tools to help in case of emergency. So here I'm thinking about things like, you know, making sure your phone is with you at all time with numbers programmed in it. Lifeline is another good example of that. There's also a service called Text with 911, which you can use if you have speech difficulties. So if you just sort of do an internet search on this, there's a process, they'll sort of show you how to get registered. So you can text with 911 instead of talking. And I'd also like to point out that Muscular Dystrophy Canada has a care and emergency card, which would have, you know, personal information about you, emergency contact information, as well as medical information. And that's really helpful to have in a handy place because, you know, if explaining all that verbally is difficult. And I'd like to give my final shout out to occupational therapists and the concept of AAC Access. So if any AAC tool or device, whether it's an alphabet board or a communication app or even a door chime, is hard to use with your hands, we can rely on the wonderful expertise of OTs who have many workarounds and gadgets that will help to make these things work. So, you know, styluses, switches, eye gaze systems, adapted mice, head controls, etc. So I think that's an important point to end on. So I guess at this point, we'll turn over to the question and answer. Thank you all for listening. It's been a pleasure to be here with you today. And so we look forward to hearing your questions.
Thank you both for a very clear and well-delivered presentation, really holistic, really covering that. How about I start with some of the treatment-related questions that I'm seeing, and then we'll go to some of the others. A lot of the questions that have been coming up from a treatment perspective is really post-treatments for SMA for adults. Is there a certain time period whereby you can see improvements in bulbar function? Is there an average? And then the other question that's connected to this, is there one treatment that's more superior in terms of providing support for bulbar function, or has that not been well studied yet?
Yeah, and so Hamira, I'm assuming you mean by treatment, you're referring to the drug therapies right now?
Yeah, so I see a question here with regards to Spinraza and then Risdiplam, and then one asking whether there's any evidence on Zolgensma and bulbar function as well.
Okay, so the Zolgensma, I did present to you, I think 3 different studies relating to that. And so that was Zolgensma was that study that looked at, so the cohort, there's a study that combined 3, a phase 1 and 2 phase 2 trials, so a total of 65 patients. And within the 8, some patients were followed for 18 months, some for 24 months. Both groups showed maintenance, because these are asymptomatic, right? So they don't start with the symptoms. They had almost entirely had normal oral and swallowing function at the 18 and 24 months. I showed you a very small study with 24 patients who were treated with nusinersen as infants, and the measure that they used did not show that there was any arrest or improvement in function, but that there still continued to be some deterioration with that one measure, and some patients did need to go on to feeding support. The study with, I think it was 24, just a second here. It was an adult study. All the patients were on nusinersen, and it was just over a 10-month period, during which time no one reported any deterioration in their bulbar function. I think what's important though is we don't have historical data on progression in bulbar and speech and swallowing. Patients with SMA type 3 and 4, you know, sort of more adult onset ambulators, generally don't have a lot of speech and swallowing or bulbar involvement. We see it most in the SMA2s, and of course the SMA1, we're just getting into the era where they've survived past age 2, where we can start to see speech functions and language functions. So all of that is really underscoring why we're trying to, everywhere around the world is trying to look at right now, what are some good measures that we can do so that we can get those answers exactly, the answers to the questions that people are asking for. Our approach, we have patients who are adults who are both on risdiplam and some who are on nusinersen. And we don't have any adults yet who were treated with Zolgensma, right? Because it hasn't been around long enough yet that we have adults yet who've had that treatment. But in our adult population, we have individuals who qualitatively tell us, gosh, I think it's better and I've improved. And so for each individual, we do assessments and we write down data and we analyze those, but you can't really pool those into a large group because it becomes very personalized, which again highlights why it would be nice to have something like the EAT 10 measure, or a maximum phonation time, or a simple measurement, mouth opening, that we could follow over time.
So I am seeing a few comments also saying that, and I think we mentioned that we were expecting this, given this comment has come through the research hotline as well, that many people with SMA haven't seen a speech language pathologist throughout their care experiences and journey and healthcare journey. And so if they were to ask their neurologist or physiatrist for that, would that be common? Is that part of standards of care? What are your thoughts on that?
I mean, my opinion that yes, it would be standard of care. We have speech pathologists involved in all of our neuromuscular clinics, including SMA. So SMA clinics, ALS clinics, muscular dystrophy clinics. We have always had speech pathologists involved. I think for SMA, because it had always been this condition that no one really ever thought of as being part of a treatment group that should be seen, followed, and rehabilitated. We're coming at it from a perspective of, we are a rehabilitation center, and the way things worked in New Brunswick is that we've always been where anybody with a chronic neurologic condition has been referred to for their rehabilitation. So it's something that's not even new for us. We've been decades of having speech pathology integrated as part of our clinics. I think we can do a much better job nationally at advocating that these are sort of the core team members that should be involved with persons who have progressive neurologic conditions. And I think some of the work that groups like Muscular Dystrophy Canada, as well as NMD4C, coming up with sort of but recommendations for how patients should be managed, not just on what tests to use, but also the resources you need then to do those tests and monitoring. Yeah.
I know we're out of time, but it'd be remiss if I don't mention this comment because it's recurring in the questions, which is also that, Susan, as you shared the pieces around communication and assistive devices, people are saying this has a direct relationship with independence and how I feel about my social life and my participation. So it's really going beyond muscles. And so to your knowledge, to both of you, is there studies on bulbar function and relationship with quality of life or psychosocial experiences? And is that specific to those in SMA, or maybe not a study in that group yet?
I certainly there in terms of different neurological neuromuscular conditions in a broader sense, those studies do exist. I'm not aware of any specifically for SMA. I'm not saying there isn't one or two out there, but it certainly is something that hasn't been looked at a lot yet, and would be a wonderful area for future research, because that's one of the most important things about our daily life. Right?
Yeah. The research that's been done with the EK2, the Egan classification 2 scale, that includes measures of quality of life and bulbar function. So there has been, and I think I put in my slide, I did have a reference to one of those. And I can send you, Homera, there's a nice sort of little review article that also mentions some of the quality of life, health, well-being, and activities of daily living and how they're impacted by bulbar functions. Most of the studies are sort of neuromuscular in general, but have included SMA patients as well. But the EK2 is quite nice, and we're seeing that it really fits nicely in that sort of group that are non-wheelchair, or sort of that are non-ambulators, people that are wheelchair users. And it brings up quite a few questions that include speech and swallowing and communication.
Very good. Well, thank you both so much. Thank you for really helping us to mark and end SMA Awareness Month on the right note. We really appreciate this presentation, and we appreciate all the engaging comments and questions as well. So wishing you all a great weekend, and thank you both for today's presentation.
Thanks,
Take
everyone.
good care. Thanks, everyone.
Bye.